السلام عليكم طلابنا الأعزاء، إن شاء الله تكونون جميعا بصحة وسلامة. Our subject is the prevention of periodontal diseases. Plaque biofilm is the etiological factor of oral diseases. Oral hygiene practices is the practice of keeping the oral cavity clean through a daily removal of dental plaque and other debris by mechanical and chemical plaque control to prevent oral diseases, most commonly dental caries, periodontal diseases, and bad breath. Plaque removal and control. Number 1, mechanical plaque control, which include tooth brushing, interdental cleaning aids like dental floss, irrigation device, and toothpick, and prophylaxis by a dentist, which include scaling and polishing. Number 2, chemical plaque control, which include fluoridated toothpaste and mouth rinses like chlorhexidine. Number 1, mechanical plaque control. Toothbrushing. Prior to that time, wooden chopsticks or a form of toothpicks were used after meals, like siwak. The conventional toothbrush is still the cornerstone of proper oral hygiene. It is composed of 3 parts: the head, the neck or shank, and the handle, as we can see in the pictures. Generally, toothbrushes are varied in size, design, length, hardness of the bristle, and even in the arrangement of the bristle. So, to overcome this variation, American Dental Association given specification of toothbrushes measurement in the following ranges. So as we see in the pictures, bristles are grouped to form tufts, and we have different types of arrangement of tuft. Bristles or filaments. The brush is made of a cluster of nylon filaments fixed firmly together and attached to the brush head. Over the year, they made from animal hair, boar or horse, to man-made nylon or polyester materials. A grouping of filaments is called a tuft. The efficacy of brushing with regard to plaque removal is dictated by 3 main factors. Number 1, the design of the brush. Number 2, the skill of the individual using the brush. And number 3, the frequency and duration of use. Soft toothbrush. It is non-traumatic, eliminates gingival incision, tooth surface abrasion, which is a classical wedge-shaped defect in the cervical area of root surfaces. Trauma to soft tissue, clean effectively when used properly. Remain effective for a reasonable time. Soft bristles are more flexible, clean beneath the gingival margin, and reach farther into the proximal tooth surfaces. Hard toothbrush with vigorous horizontal brushing. The use of extremely abrasive dentifrices may lead to cervical abrasion of the teeth and recession of the gingiva. Toothbrush need to be replaced every 3 months. Here in this picture we see the cervical abrasion caused by vigorous toothbrushing. The features of an ideal manual toothbrush should include: Number 1, handle size appropriate to user age and dexterity. Number 2, head size appropriate to the size of the patient's mouth. Number 3, use of end-rounded nylon or polyester filaments not larger than 0.009 inches in diameter. Number 4, use of soft bristle configurations as defined by the acceptable international industry standards ISO, because too stiff brush will harm the soft and hard tissues. Number 5, bristle patterns, which enhance plaque removal in the proximal spaces and along the gum line. We have 2 types of toothbrushes. either mechanical or electrical. Electric toothbrushes, electrically powered and manual toothbrushes are identical in terms of plaque removal. I will repeat, they are identical in terms of plaque removal. The choice of any one can therefore be left to the patient. Electric powered brushes are recommended for number 1, individuals lacking fine motor skills; 2, small children or handicapped or hospitalized patients who need someone else to clean their teeth; and 3, patients with orthodontic appliances. Overzealous or harmful brushing can lead to gingival recession, bacteremia, especially in patients with pronounced gingivitis, wedge-shaped defects in the cervical area of root surfaces, painful ulceration of the gingiva. This type brushing should be identified and discouraged. Now we will discuss the interdental cleaning aids and devices. An efficient toothbrushing technique only cleans approximately 65% of the tooth surface, leaving the interdental area untouched. Therefore, toothbrushing alone cannot effectively control interproximal plaque, and adjunctive methods of cleaning are required. However, not all interdental cleaning devices suit all patients or all types of dentitions. Factors should be taken into consideration when selecting an interdental cleaning method, such as the contour and consistency of gingival tissues, the size of the interdental space, tooth position and alignment, the ability and motivation of the patient. Interdental cleaning aids include dental floss, interproximal brush, toothpick, dental irrigation devices. Dental floss. Dental flossing or type of broader dental floss is the most widely recommended method of removing plaque from proximal tooth surfaces. Floss is available as a multifilament nylon yarn that is twisted or non-twisted, bonded or non-bonded, waxed or unwaxed, thick or thin. For cleaning narrow gingival embrasures that are occupied by intact papillae, dental floss is the most effective dental hygiene aid. Here we can see the method of using dental floss. The loop technique for flossing. With the floss anchored to the middle finger, it is stretched between the forefingers to access posterior teeth. With the floss anchored to the middle finger, it is stretched between the thumbs to access teeth more anteriorly. Dental floss also can be provided with a holder. Interdental brushing, as we see in the pictures, the interdental brushing can be used in case of the spacing between teeth or in case of wearing orthodontic appliance. Wooden tips or toothpicks. Stimulant. For interproximal slightly open spaces, plaque removal is accomplished by horizontal back and forth movements. As a summary, dental floss indicated for narrow interdental spaces, toothpick for slightly open spaces, and interdental brushes for interdental spaces that are wide open and for root irregularities. Oral irrigation devices are also used for mechanical plaque control. There are several types. Number 1. Use water faucet to irrigate between and around the teeth. The water is steady and is controlled turning the fenced handle. 2. Use an intermittent water jet. C. Silvadora persica, chew sticks or miswak. Wood is a very good substitute for modern plastic brushes to clean teeth. When damp, wet, the softened cellulose fibers mechanically disturb plaque and can remove toxins from the biofilm. The wood itself has antimicrobial properties and also contains fluoride. The miswak is a good alternative to a toothbrush and is certified by the World Health Organization. Tongue scrapers. The dorsum of the tongue harbors a great number of microorganisms. These bacteria may serve as a source of bacterial distribution to other parts of the oral cavity. It also may be the source of bad breath. In the pictures, we see different types of tongue cleaners or tongue scrapers. Dentifrices or toothpaste. A dentifrice is usually used in combination with toothbrushing with the purpose of facilitating plaque removal and applying agents to the tooth surfaces for therapeutic or preventive reasons. The major ingredients of toothpaste: number 1, abrasives such as silica, alumina, dicalcium phosphate, and calcium carbonate, either alone or in combination. The addition of abrasives facilitate plaque and stain removal without producing gingival recession or tooth abrasion, or altering the remaining components of the dentifrice. 2. Detergents. The most common detergent used is sodium lauryl sulfate, which imparts the foaming property to the product. Additionally, detergents may help dissolve active ingredients, and it may have both antimicrobial and plaque inhibitory properties. 3. Thickeners such as silica and gums. 4. Sweeteners including saccharin. 5. Humectants, notably glycerin and sorbitol, to prevent drying out of the paste once the tube has been opened. 6. Flavors, of which there are many, but mint or peppermint are popular. Coloring agents could be added as well. 7. Active substances claiming anticaries like fluoride, antibacterial like chlorhexidine and triclosan, anticalculus as pyrophosphate, and desensitizing properties like strontium. 8. Binder, for example carboxymethylcellulose. Chemical plaque control agents. Most chemical plaque control agents have been formulated in form of mouth rinse vehicle, which is vary in their constituents. They can be simple aqueous solutions, but the need for products to be stable and acceptable in taste usually requires the addition of flavoring and coloring agents. Effective antimicrobial plaque agents show prolonged persistence of action in the mouth. Substantivity. To date, 2 agents have been accepted for the treatment of gingivitis: chlorhexidine and Listerine, stannous fluoride and triclosan. Oral hygiene products are available with proven anti-plaque activity. Chlorhexidine, it is one of the most effective anti-plaque agents. It is a cationic compound that binds to the hydroxyapatite of the tooth enamel, to the pellicle, to plaque bacteria, and to the mucous membrane. It is absorption to the hydroxyapatite believed to inhibit bacterial colonization. After binding, the agent is slowly released in active form over 12 to 24 hours. Chlorhexidine gluconate 0.2% is used twice daily as a mouth rinse. Chlorhexidine is bactericidal and effective against gram-positive, negative, and yeast organisms. There are local reversible side effects like brown staining of teeth, tongue, silicate resin restoration, transient impairment of taste perception. It has a very low systemic toxic activity in humans, hypersensitivity, and mucosal desquamation.